The next topic is about V Q scans, which we do quite frequently in all the departments. And currently there's EANM recommendations that we should move from planar imaging to SPECT imaging. The only reason is they want to have a holistic approach. Holistic approach means what the EANM recommends is when you report a VQ scan, you have to be saying positive for PE or negative for PE. So they have taken out all the probability scans. In the past, we used to say it's a low, intermediate, and high probability. So currently, the recommendation is we need to be specific whether there is PE or no PE based on the VQ scans. So I'll cover all these aspects for the next 20 minutes. In fact, 13% of autopsies, PE was considered to be the main contributory cause of the death. Risk increases as we get older. Similar incidents, whether you're a male or a female, you are prone to PE. In patients with proven leg DVT, approximately 40% will have asymptomatic pulmonary embolism. And mortality is higher for PE than for DVT. DVT is again whether it's above knee or below knee. Based on that, they plan the management. The risk factors for PE include inherited and acquired factors. So the acquired factors especially include malignancy, recent major surgery, long distance flights, or other any SLE, pregnancy and postpartum are one of the problems for acute pulmonary embolism. VQ scan imaging test, it shows ventilation perfusion mismatch, indication for PE, whereas for CTPA you have intraluminal filling defects in the pulmonary arteries. In a chest X-ray, it's quite non-specific. You see other Westermarck sign, Hampton's hump, all these are non-specific findings. Resolution of pulmonary embolism is variable. Majority of the patients will have resolved or unresolved PE at 6 months from diagnosis. Rapid resolution of PE occurs when you treat them appropriately and adequately. And within 1 week, most of them respond to treatment and most of the PEs get resolved. In general, imaging tests should be done as soon as possible. In fact, preferably within 24 hours of onset of symptoms, especially nuclear medicine scans. So the current EANM recommendation is based on the clinical probability. If it's a low probability, they'll have a D-dimers. If D-dimers is negative, it's unlikely to be pulmonary embolism. If D-dimer again, which is non-specific, but still if it is positive, the patient should be recommended either for a VQ scan or a CTPA. If it is other than low, and if you have no clue, then the best thing is to go for a VQ or a CTPA. That again, it becomes regional whether you want to go for a CTPA, because most of the departments are switched over now. They directly go for a CTPA than for a VQ scan, unless the patient is pregnant or has got a contraindication like renal insufficiency or any other contrast allergies. They usually go for a CTPA, otherwise they go for a VQ scan, otherwise most of them do a CTPA. The reasons being that it's a 24-hour service, 7/7, whereas nuclear medicine we work from Monday to Friday. There is no weekend service, and also CTPA takes just a minute. But the only problem is often if you don't image it appropriately and adequately, nearly 20 to 30% of the CTPAs can be inadequate and ininterpretable. Coming to radionuclide imaging, I think majority of us know we use perfusion tracers and ventilation agents, and we use krypton in our department, but still it's high cost, but we do about 3 to 4 scans per day, and therefore it's quite cost effective. Whereas coming to Technigas, it is quite commonly used in Australia and other centers, but we had some local problems within the Technigas because of too much of heating and other things. But the EANM and even the Australians, they use quite a lot of Technigas, which they said is an ideal agent because the particle size is small, it's got a better alveolar penetration, therefore your quality of image is better, and it's also low cost. And also it causes less central deposition, especially in patients with COPD, especially DTPA aerosols is a disaster. In fact, it causes quite a lot of problems and most of the scans becomes indeterminate or ininterpretable. So protocol for perfusion agents is you inject technesium MAA. If you're doing a SPECT scan, we double the dose approximately from 100 to 250 megabecquerels. And this again, it's a local protocol, how much you want to do. But if it's a pregnant, if it is more than 24 weeks, we do as a general protocol. But if it's less than 24 weeks, we do a half dose activity, which is approximately about 100 or 150. VQ planar, we moved on from that, but initially the recommendations is once you directly skip to VQ Spect, it's quite challenging to report these scans because it's quite sensitive. It may pick up all these smaller defects, but there is a technique where you can image the SPECT, you can reformat it to planar images. So initial stages when you switch over from planar to SPECT, it's better to have both when you report, and therefore you become more comfortable over a period of time. So you can always reformat a SPECT image to a planar image. And E&M guidelines again do not recommend CT at this stage. They only talk about VQ Spect, but few centers have moved little bit further doing SPECT CT, and also few centers in Australia, they do only the perfusion image and they replace the ventilation with CT. So they say CT, but I don't believe in that, because again in bronchospasm and other things your CT can be quite normal in patients with asthma and other things. So but few centers use VQ perfusion SPECT only, followed by CT as a perfusion as a ventilation image. VQ planar, this is how the images used to look: normal perfusion, normal ventilation, perfect, no evidence of acute pulmonary embolism, and the perfusion has got multiple defects. Perfusion ventilation is normal, then it's multiple PE, and if it's matched, again we used to call it as equivocal or indeterminate scan. This patient, though it's matched, likely to be infection or inflammation, but you can't exclude PE in these cases. Limitations of VQ planar scans is a two-dimensional technique. Anatomical segments often overlap. Accurate determination of the burden cannot be explained. Assigning defects to a specific segments could be challenging. Extent of perfusion can often be underestimated. Shine through, you can miss smaller defects. Right lower lobe, especially the medial segment, is often not seen on your planar VQ scan, therefore you can miss some smaller P's. Probabilistic criteria is a huge debatable, because once you say low probability, it means you've got 20% chance of PE. So how can you have 20% chance and still you call low probability? If you say low probability, the physicians often mistake low probability for a normal scan, so that can cause quite a lot of problems. And also when they did the PIOPED criteria, they didn't tell us that most of the patients included in the criteria were inpatients in that hospital. So if you have an inpatient, it's unlikely that they will have a normal chest X-ray. Often they'll have some sort of infection or inflammation going on in the lung. And in fact, majority of the scans on the planar in that criteria was indeterminate were high. If it is indeterminate, then it's challenging that all patients has to go for a CTPA to exclude PE. And there is quite a lot of clinician satisfaction. So if you say, you are saying it's a low probability and you've got a 20% chance, then that's not a real low probability. And they made a modified criteria saying it's very low probability. It means again 5%. So you mean to say you're normal, but there's a 5% chance that you may have PE. It's not an adequate answer for the clinician. So he wants us to tell whether it's PE or no PE. VQ Spect, in general, it takes about 20 to 30 minutes. You can review the images on the workstation. And as I said in early images, if you can always reformat, the planar images can be regenerated from the SPECT images if you're not comfortable. But without the CT, I feel, it's my personal, I mean, it's the departmental opinion also, is you'll be slightly overcalling smaller perfusion defects when you're reporting based on the SPECT. And there are some false positives, which is very clear cut on the SPECT images, but using the SPECT CT, you can eliminate the false positives. Advantages of SPECT is three-dimensional. There is no overlap of segments, avoid shine through, and you can size the defects, you can localize the defects. It's got higher sensitivity, less inter-observer variability, higher specificity. So you often get a better diagnosis. But only thing is, if you have a small single subsegmental, don't call it as a PE. It again, that's what the E&M guideline says, but you should be careful. You have to correlate with the clinical probability. If the patient is sick and there's high probability, it is always wise to call, even if it's a smaller defect, to treat it as a PE. Though 10% of the patients will have problems to your thrombolysis, there is 10% complications in most of the patients, but you should not take that as a guideline. If it's a single defect, you should not say it's single defect is unlikely to be PE. You have to take the clinical probability into consideration and then phrase it accordingly. So if it is a long haul flight, if the patient's got a single subsegmental defect, then according to the E&M criteria is not diagnostic for a PE. But if you have two subsegmental unmatched defects, then it should be taken as PE. Current evidence for role of SPECT, this is just SPECT, found that SPECT to be more sensitive than planar imaging and demonstrated that SPECT was more specific than planar imaging, and also they said SPECT has better reproducibility when compared to the planar imaging. And SPECT sensitivities ranged from 80 to 100% and specificity to 93%, and by converting from planar imaging to SPECT, the reporting pattern was yes or no rather than indeterminate findings. So there may be less than 1 to 2% of the scans you cannot diagnose PE. In those cases you have to recommend for a CTPA. How the V Q Spect should be reported is part of the EANM guidelines. If it's a ventilation perfusion mismatch of at least one segment or two subsegmental defects, then it is taken to be as a PE. But again, caution here, even if it is a single subsegmental defect, correlate with the clinical probability. Don't just undercall it. No PE is reported if the perfusion pattern conforming to the anatomical boundaries, matched or reversed mismatch is not a criteria for PE. And also they say even if it is extensive multiple match defects, it is unlikely to be PE, because they have a ventilation perfusion quotient which can tell whether it's a matched or a mismatched defects. This is a normal V Q Spect scan. The top bit is the ventilation, the bottom is the perfusion, uniform and normal. And this is how the pictures will look like. You'll have 3 axial pictures for V Q Spect. And if it is abnormal, it is abnormal as any other consensus. Normal ventilation and perfusion shows multiple defects, and the bottom one is the ventilation perfusion coefficient. So in people who are in early, it's exactly like bullseye quantification in myocardial perfusion, though you can't use bullseye as an independent way of reporting reversibility, whereas in V Q scans you can add to your diagnosis. For example, that's the ventilation and this is the perfusion, and the subtracting these both, it gives you all these red areas or the abnormal areas, which is clear cut for pulmonary embolism. And if you have a Hermes package, I think so it's part of the Hermes package. This is an example of a positive PE. Perfusion ventilation looks normal, perfusion shows multiple defects which is unmatched on ventilation, so it's a multiple pulmonary emboli. And this is another example of a normal ventilation, abnormal perfusion. Using V Q quotient, it says these are the areas which is involved for as mismatch areas. So especially this is quite useful if you have a small subtle defects, but you should be careful when you are using the ventilation perfusion quotient. If there is patient movement between the ventilation and perfusion, it will show some diffuse red areas. If it's quite diffuse throughout the lung, it is often definitely due to patient motion. And also you should careful to use the V Q quotient, because during ventilation the size of the lung is quite longer when compared to what you see on the perfusion, because they keep breathing during the ventilation, and even that could cause a diffuse mismatch at the base. It will be quite diffuse. If it's quite diffuse, it's unlikely to be PE. If it is quite diffuse on this side, what has happened is the perfusion has moved, the patient has moved on this direction, and therefore you will say a false positive area, that area. But if you, most cases, ventilation perfusion quotient is useful to increase your diagnostic confidence. Strengths of SPECT, as I said, it's got high sensitivity, high specificity, low radiation dose, rare technical problems, there's no allergy, no contrast problems, useful in chronic PEs and useful in follow-up. Whereas limitations of SPECT is because you don't have a CT, it is not going to provide any alternative diagnosis. Just like a planar V Q scan, you have to talk only in terms of PE but not any other pathologies. And also if you have a chronic COPD and other problems, if you are using technetium DTPA, then you are going to end up in problems because of the clumping of aerosols. SPECT versus CTPA, and SPECT is more sensitive when compared to CTPA, and SPECT versus 16-slice CTPA found the accurate results, it's most comparable. So if you say CTPA is better, it's not better, it is more or less the same. And also SPECT has a higher sensitivity and specificity but lower specificity when compared to CTPA. SPECT has got higher sensitivity, CTPA has got higher specificity, overall accuracy of both, whether you can use a CTPA or you can use SPECT, both are also more or less comparable, but depends on individual centers whether they prefer CTPA as the first line of investigation or VQ scan. Even in the busy radiology departments, usually they don't want to do CTPAs, they always push it to nuclear medicine to have the VQ scan first. Whereas if you have a CT scanner in the A&E, especially in the weekends, I think so CTPA should be the first choice. VQ, skip this. This is a normal VQ SPECT. We do a low dose CT for in all our patients. So that will also is useful because most of the patients with chest pain or breathlessness and all sorts of things referred for a VQ scan will have a chest X-ray to start with. But if you're doing a low dose CT, you can avoid the basic baseline chest X-ray and send the patient directly to VQ scan. But again, some people can argue, what if the chest X-ray is abnormal to start with, then you can avoid sending them to VQ scan, they can go directly to CTPA. So you can have a debate on that. But in our place now, all patients referred for a VQ scan except pregnancy will have a SPECT CT scan. This is a ventilation scan, a perfusion, normal, and it doesn't have much here, but in about 10 to 20% of the patients we picked up some additional findings which was relevant to the clinical management. This one is ventilation, perfusion, there is a defect which is unmatched, and on the CT you can say exactly which part is involved. This is another matched defects, that is the ventilation images. This is the perfusion images, there is a matched ventilation perfusion defect, although the CT looks more or less normal, there is hardly any CT abnormality there. This is matched defects again, the patient has got significant emphysema, as you can see there is a large bullae. Again, those things can easily say what is the pathology is, rather than saying there is a matched defects, possible infection, inflammation, we can specify the pathology in these patients. VQ quotient, as I said, it is if you have a Hermes package, they have this as a part of their viewing station package. That is the ventilation scan, that's the perfusion scan. You subtract whatever you see as a red is the perfusion defect, unmatched perfusion defects. So if you have a problem in terms of increasing your confidence level, if you think it is a PE and if it shows red in this area, you can easily go to the higher level and say it is likely to be positive, rather than saying it's an equivocal study. This is how the ventilation perfusion quotient will help. Ventilation normal, perfusion shows multiple defects, and if you subtract those things and you get a VQ mismatch. And also this is quite useful if you are going to see more than 2 defects or 3 defects, it can say exactly there are 1 or 2, it is easy to map, and medical legally you can also be protected saying that I stick to the guidelines, because the guidelines also recommend to look at the ventilation perfusion quotient. Mismatch, that is again a VQ quotient showing a defect, there is a mismatch, but I will tell you the problems related to the mismatch. Match defects, if you have a defect like that, again the perfusion looks relatively better than ventilation, and on the CT scan you can see there is atelectic changes with consolidation, so therefore you are quite confident, you know that there is something happening there, you can give a definitive diagnosis. Strengths of SPECT CT has got a high sensitivity, specificity, low to moderate radiation dose, because you are doing a CT, the patient will get an extra 1 to 2 millisievert when compared to 1 millisievert again they get for VQ scan it is approximately about 1 millisievert. By adding the SPECT CT, because we are doing a low dose SPECT CT, we give them an additional 1 millisievert radiation dose. And most important thing is it provides alternative diagnosis. Whenever it is normal, the patient is still breathless or it's got chest pain, we often find pleural effusions, we often find other pathologies which I will show. Normal variants, we should not over-report. As in planar imaging, there is cardiac impression, that should not be taken as a defect, and vascular structures do come in, the pulmonary vessels, you cannot over-report that as defects. If it's central, you should not worry too much about central defects as in planar imaging. That's again pulmonary vessels, that's a normal variant, that's a normal area, so don't over report that as a defect. And but I'll come to this. There's the most challenging bit. This is the most tricky bit, why people over report on a SPECT. Some people will say planar imaging is much better than SPECT CTs. Sometimes I also do feel that I should have stuck to planar imaging, which was more easier to say yes or no, because that's the normal ventilation. Okay, on the perfusion you are seeing a defect. All right, without the CT I would have called it as abnormal, but with the CT that defect corresponds to a fissure. So fissures are avascular and therefore it will not show perfusion. So without the CT bit I will overcall these defects. Ventilation is normal, perfusion is abnormal, but if you could see exactly here, there is a defect there on the perfusion, it matches to the fissures. The fissures, because it is avascular, will show reduced perfusion. There is a chance that you will overcall it as a defect. So it's very common, especially on the right lung you often see it in this area, and then left lung you often see it as a base area. As soon as you see it on your SPECT images, I know that it's a fissure and I'm not going to call it. This is again, that's how the fissures will look like. All these are fissures. That's the fissure, that's the fissure. And often, especially if you come to the base, you should be quite careful, because the liver comes into the region, that is due the liver, dome of the liver, and that you cannot overcall it as a defect. Incidental findings, you can see it's all normal scan, but on the CT you are picking up a paraseptal emphysema. We pick up some lung nodules, and this has got an emphysematous bullae. This patient's got multiple bullae like this, which are match defects. So all these extra diagnoses you can get by doing the CT bit. Otherwise, I think we'll be slightly overcalling PEs if you're doing only SPECT in these patients. Radiation, this is the last bit I will cover. Radiation is not that bit, because if you use a CTPA, it's about 5.4. If you use a high level 64 slice, it is approximately around 20 millisievert you are going to give, and absorbed dose to the breast is about 35 to 42 first trimester, and dose to the fetus has also been explained. So in general, if you are doing a V Q Spect, the effective radiation dose is about 1.2 to 2 millisievert. If you add a low dose CT to that, the radiation becomes 1 millisievert more. Totally for 3 millisievert you can do a SPECT CT. So conclusion, V Q Spect is useful, but as a learning curve it is better to use both planar and SPECT to start with to get a better confidence level. But if you add the CT bit to the V Q Spect, you can find some additional findings and you can negate all the false positives. And it's got a higher reproducibility, greater specificity, and indeterminate results are low. In fact, in our department, 90% of the scans we call it as a positive or negative, and we don't call it based on the probability. So we always give it as yes or no rather than low, high or intermediate.